So welcome to the thoracic ultrasound module of the Sheba point-of-care ultrasound course. I'd like to show you some of the basic and fundamental aspects of lung ultrasound in the next 50 odd slides. Firstly, we start with a typical ultrasound machine, in this case with three probes, a curvilinear low frequency probe, which is very useful for lung and abdominal ultrasound. Secondly, a linear higher frequency probe used for superficial work and vascular access. And in this particular machine, which we use in the pleural clinic, we have a small footplate biopsy probe. But on many of your machines, you'll also have a cardiac probe, which you'll be using for echocardiography. The machine looks very complicated at first glance, but has a fairly standard selection of buttons, including the on-off button, a keyboard for inputting patient information, a variety of buttons to retrieve and to store patient information, and then of course a series of imaging modes, including B mode, M mode, and Doppler, which we'll talk about a bit later on. Then of course you have depth, gain to alter the brightness of the image, focus to define a focal point, and a variety of other image optimization modes, including time gain compensation, which can alter the brightness at different levels in the image. Then of course there are buttons to enable you to measure and buttons to enable you to freeze and record images. So this is a fairly standard set of functions on a medical ultrasound machine, and these are the basic functions that you need to get familiar with in your machine, in your work environment. In terms of common ultrasound probes, we've briefly already mentioned the curvilinear probe, which is a 1 to 8 megahertz probe, very good for imaging structures in the chest and in the abdomen. The linear probe is a 5 to 13 megahertz probe, and usually used for imaging structures at a depth of up to 4 to 5 centimeters, and provides a higher resolution. And then of course the phased array probe, which is a very good multifunctional probe, scanning between 2 and 8 megahertz, which is extremely good for looking between the ribs at the heart and performing echocardiography, and can be used as a general purpose probe in lung ultrasound. In terms of imaging modes in lung ultrasound or thoracic ultrasound, there are some terms to be familiar with, including B mode, which is the so-called brightness mode or standard two-dimensional image. And typically when we orient the probe, we say cranial to the left of the image and caudal or the feet towards the right. Deeper structures are lower in the image, and superficial structures are towards the top of the image. M mode or movement mode is a method by which you can define movement of structures along a certain line, and this line can be maneuvered so that it passes through a structure of interest. We'll see that this is quite useful for assessing for pneumothorax, for example, and also looking at diaphragm movement. Doppler is a imaging mode used for assessing movement, and there's a simple mnemonic that tells you which way the movement is occurring relative to the probe. So blue away and red towards, but, and for the purposes of lung ultrasound, thoracic ultrasound, we typically use color Doppler. Probe orientation is very important, and you'll notice that on your machine the probes will have some form of marking on one side, which corresponds to a marker on the screen. So Typically, as I said before, in thoracic ultrasound, we say cranial or head to the left and feet or caudal to the right. So you need to orient the probe so that the probe marker on the screen corresponds to the probe marker on the probe. And so the general setup for thoracic ultrasound usually involves using either a low frequency abdominal probe or the phased array probe set at a lung preset, with the focal point, and we'll talk about this a bit later on, set at the pleural line and an image depth of 10 to 15 centimeters. The image on the right of the slide shows you different movements of the probe to help with image optimization, including downward pressure on the skin, moving up and down, rotation of the probe, and tilting of the probe as well. And patient examination can be performed either with the patient sitting or with the patient supine. Ideally, if you can get the patient into a sitting position, it's a more thorough examination. The key to examining the patient in this setting is to have a systematic way of examining the chest on the right and the left side. And one of the common ways of doing that is by dividing the right hemithorax and the left hemithorax into 4 to 6 zones. So for example, in this image, you can see R1 to R6 with lines dividing these areas. So for example, the right hemithorax on the medial aspect is the parasternal line, and then you have the anterior axillary line and the posterior axillary line separating the front of the chest from the posterior R5 and R6 zones. In the supine position, it's harder to examine the posterior chest, but you can divide the hemithorax into 4 zones: superior, inferior, anteriorly, and laterally. And the most lateral and posterior examinable section can be divided into the Plapp's point and the phrenic point. Now these are important areas, as you'll see in lung ultrasound, because they help to define the caudal-most extent of the lung cavity, where it meets the diaphragm and then the abdomen starts, and also is the most dependent examinable area in which you look for pleural effusions and dependent lung changes. When recording your findings, it's useful to use standard terminology, and this slide gives an example of the sorts of terminology that can be used, and also to record your findings in each of the examined areas, whether it's 4 spaces in the supine patient or 6 areas in the sitting patient. And again, as we'll see a bit later on when we go through some examples, the distribution of findings can be as valuable as the findings themselves, because they can help to narrow down the differential diagnosis. So the general steps for performing an ultrasound examination, whether it's lung ultrasound or any ultrasound examination, can be split into 4 different aspects. So firstly, you need to make sure you and the patient are comfortable. The machine should be within reachable distance so you can adjust the settings while you're examining. And you need to also decrease the ambient light around the machine and the patient so that you can see the image clearly on the screen. The second aspect is choosing the most appropriate probe for the task in hand, then checking the probe orientation and ensuring that there's plenty of gel on the probe so that you've got good probe to skin contact. After you've done this, the next step is image optimization, where you adjust the overall brightness, called the gain. You adjust the depth of the image so that the image depth is not too deep for the structure you want to see and not too superficial. You can use a rotating dial or a touch pad to adjust the focal point, which is the point of maximal lateral resolution on the screen, and this is usually a small marker on the side of the screen that moves up and down. And you adjust it so that it's lying at the level of the pleural line for general lung ultrasound, or at the level of whatever structure you'd like to visualize best. And of course you need to choose your imaging mode. So as we said before, there are 3 general imaging modes called B mode, M mode, and Doppler. Typically examinations start with B mode, 2-dimensional brightness mode, and then as you progress through the examination you might want to use M mode or Doppler to get more information. And of course, once you've done the general image optimization, the final step is fine adjustments using other functions such as zoom, adjusting the probe frequency, and occasionally image steering to look at flow, for example, with Doppler. All of these things are important aspects of acquiring an image, because thoracic ultrasound is entirely operator dependent. And as a summary for lung Pocus, you can think of it as starting with typically a low frequency probe, so a curvilinear or phased array probe, performing a systematic examination, either 4 zones in each hemithorax or 6 zones. And what you need to ask yourself is, firstly, can you see something called lung sliding? And we'll go through this in the next few slides. Do you see any artifacts or other signs such as consolidation or pleural effusion? If you suspect a pneumothorax, you need to confirm it by finding something called the lung point or lung pulse. And once you've gone through these lung Pocus aspects, you need to think, okay, what other additional information do I need to gather to come up with a diagnosis? And this may include echocardiography, it may include venous assessment to exclude deep vein thrombosis, and these are aspects that will be covered in the other parts of the course. Of course, anything you find in lung ultrasound needs to be put inside the clinical context, and also any additional radiology, including chest radiography or CT scanning, so that you can arrive at a diagnosis. So moving on to the basic principles of ultrasound in general. So ultrasound using a standard transducer relies on the generation of sound waves, high frequency sound waves, which penetrate tissue and then reflect to varying degrees back to the probe, and then this sound reflection is converted into an electrical signal and thence to a visual image on a screen. Various tissues reflect sound waves to different degrees, and the difference in transmission of sound waves between tissues, so-called acoustic impedance, also determines the amount of reflection back to the transducer. Now, to be able to see anything with ultrasound, you need reflection of sound waves back to the transducer. And there are some surfaces or structures that reflect sound waves better than others. So, for example, a good specular transducer, reflector, such as the diaphragm, is an ideal reflector, and therefore you can get a very clean, crisp image of the diaphragm. Whereas other structures where the sound waves hit them and are refracted, so move off in different directions or attenuated or scatter, don't tend to reflect very strong sound waves back to the transducer, and therefore you don't get very good, clear images. So an example of this in practice would be This little video clip of a small pleural effusion with the lung, the diaphragm to the right, and the liver, and also some fluid underneath the diaphragm, in this case ascites. And you can see, for example, the sound transmission comes from the probe contact with the skin, passes through subcutaneous tissue and muscle. It hits the parietal pleura, and then there's some reflection back to the transducer. Some of the sound waves carry on through the pleural fluid, and they hit the lung and the visceral pleura. The lung, of course, contains a lot of air and provides a lot of acoustic impedance. So what you see is reflection from that interface back to the transducer. And the other thing you also observe in this image is that the area beyond the pleural effusion, therefore the lung tissue, is very, very hyperechoic. That means bright. And this is partly a function also of the sound wave traveling faster through fluid medium before it hits a structure where the sound waves are slowed down, creating this very bright echogenic structure. And you can see it as I play the video. Another example of this so-called posterior acoustic enhancement, where sound travels very quickly through fluid and then reflects off a structure posteriorly where the sound waves travel at a slower velocity, is this example on the right, where there's a large pericardial effusion and the ultrasound reflects off the pericardium posterior to the heart. The opposite of this is what we call acoustic shadowing, where sound waves hit a structure that's a very good attenuator. Maybe it absorbs the sound waves efficiently, and as a result, distal to that structure you get a hypoechoic or dark region, sometimes with surface increased reflection. So, for example, the image on the left shows a so-called rib shadow, which is a very common feature in lung ultrasound and a useful feature. Incidentally, to the left of the rib is lung with a very hyperechoic pleural line. Another concept that's extremely important in lung ultrasound is reverberation artifacts. And this is a type of artifact where sound waves that are transmitted from the probe hit a structure, which then bounces back to the transducer and then back to the structure and back to the transducer repeatedly. An example of this might be sound waves hitting the pleura or hitting the diaphragm, which is a very good reflector. Now what happens is that the machine assumes that the returning sound waves are coming from deeper and deeper structures within the image, rather than from the same structure repeatedly backwards and forwards. And what it therefore does is that it generates a corresponding image on the screen of a repeating artifact. And we'll see some of these artifacts in the next few slides. So these are some of the common types of reverberation artifacts that we see in lung ultrasound. The so-called A lines, seen on the left, top left here, which are horizontal hyperechoic lines. You'll notice that the spacing between these horizontal hyperechoic lines is consistent and corresponds to the spacing between the probe and the pleural line. So essentially these are reverberation artifacts where you're looking at the reflection from the pleural line. And this is a normal lung artifact. The next very common, very important reverberation artifact to be aware of are the B lines. And these are artifacts caused by reverberation between the interlobular septi and the transducer, and generate these hyperechoic lines that move with the pleural line and extend from the pleural line to the bottom of the screen in a sort of laser type pattern, or rays of sunshine type pattern. And these are a very important artifact, which we'll see in the next few slides of lung pathology. And of course, then there's the mirror image artifact, which is another type of reverberation artifact, typically involving the diaphragm, where, for example, in the bottom image, you can see to the left of the diaphragm, there's a attenuation very similar to liver. So it almost looks like lung consolidation or liver to the left of the diaphragm, but this is simply an artifact and doesn't reflect any pathology. So B-line artifacts, there are some features that need to be recognized. So these are hyperechoic lines that do not fade, and they tend to widen from the pleura to the edge of the screen. They move with lung sliding. They erase the horizontal hyperechoic A lines. Less than 3, so up to 2 in one intercostal space is considered normal. More than 3 is abnormal. And these lines tend to be more common in dependent areas, typically because the interlobular septi are more likely to be thickened in dependent areas due to pulmonary venous or lymphatic congestion. You may also hear about a term called lung rockets, which one of the pioneers of lung ultrasound and Pocus, Daniel Lichtenstein, coined this term called lung rockets. And these are more than 3 B lines in an intercostal space, and this is an abnormal finding. So if you mention the phrase lung rockets, you're saying that there's an abnormal number of B lines in a particular part of the lung. And as we'll see a bit later on, depending on the ultrasound distribution and the clinical context, lung rockets can mean pneumonia, pulmonary infarct, pulmonary contusion, lung fibrosis, ARDS, pulmonary edema, and in this day and age, COVID-19. So this is a very important sign to detect and also to describe accurately. It can sometimes be confused with something called Z lines, which look like B lines, and these are common normal lung findings. These are hyperechoic lines originating from the pleural line, which also move with pleural line movement, but they do not obliterate the A lines, and they do not extend from the pleural line to the base of the image, and they certainly don't maintain their intensity or get larger at the base of the image. It's important not to confuse true B lines, as in the right-hand video, with Z lines, because Z lines are a normal finding. Here's another video demonstrating A-line artifacts. So again, these are hyperechoic, that means white or bright, horizontal lines parallel to the pleural line, showing equal spacing, and the spacing is the skin to pleura distance, or transducer to pleura distance, and this is a normal lung artifact. Another important sign to detect in lung ultrasound is the sliding pleura sign, demonstrated here with the 2 videos. And this is a hyperechoic line showing a shimmering and an image of some form of movement. And you can visualize this very well by holding the probe in a vertical position, generating the 2 rib shadows on either side as a contrast to the pleural line in between. The pleural line can be seen effectively using a low frequency probe or the high frequency linear probe. And another term that you may hear mentioned is the so-called C-line pattern, and this is simply a description of subpleural consolidations. In this video you can see that the hyperechoic pleural line, which is sliding, therefore moving left and right, which is a normal feature, doesn't look like a smooth hyperechoic line. There are little hypoechoic subpleural areas, which are little subpleural consolidations, occasionally with some vertical reverberation artifacts coming off them. And this can be an indication of, again, multiple pathologies, including COVID-19, types of pneumonia, pulmonary infarcts. Even it can also be seen in lung fibrosis. So it doesn't specifically point at one particular diagnosis, but is a feature of many conditions. And you'll have to use additional imaging and clinical findings to come to a diagnosis. And then, of course, consolidation is quite easily seen with thoracic ultrasound if it's peripheral, of course. And there are a variety of descriptive terms given for consolidation. So the so-called shred sign seen on the left-hand image is a segmental or sublobar consolidation, and this is a hypoechoic zone with a very irregular edge, a so-called shred sign edge, like ripped paper, and within it you can see the hyperechoic dots are air bronchograms, so air is white on ultrasound. And on the right-hand image you can actually sometimes see dynamic air bronchograms where you see little bubbles of air shown as these little hyperechoic dots moving through the consolidated lung. Of course, a Doppler can also be used to visualize movement within the airways and to ensure that you're looking at lung rather than heavily organized pleural effusion, as an example. So on the left here you can see a standard B-mode image of what appears to be consolidated lung with some hypoechoic areas that look branching within it. And then when color Doppler is applied, you can see the branching structures extremely well. Now these branching structures are not blood vessels, these are bronchi with fluid, pus, within them. So there's movement of fluid within the bronchi. Ultrasound, of course, is also used to identify diaphragm movement and can be extremely useful for diagnosing diaphragm paralysis in patients presenting with breathlessness or respiratory failure. And we look for something called the curtain sign, where when the patient breathes in, the lung moves across like a curtain being drawn and obscures the image. So on the left side you can see the diaphragm as this line to the left of the liver, and as the patient breathes in, the diaphragm moves down and the lung obscures the image. And on the other side it can be more challenging to identify the left-sided diaphragm because you have to use a smaller organ, the spleen, as your acoustic window, but you can sometimes position the probe posteriorly and get a better visualization, and you're looking for the same downward movement with breathing in. Pleural effusions are another very easily detectable pathology on ultrasound, and ultrasound can pick up and identify a few cc's of pleural fluid compared to a standard chest radiograph, which typically requires around 200 cc's of fluid before being noticed on the film. There are a lot of features of pleural effusions which could be discussed, but keeping it fairly straightforward for the purposes of this presentation, a pleural effusion is typically hypoechoic, a dark area. The darker the fluid looks on ultrasound, the more likely it is to be lacking in cellularity and protein content. But you cannot say that if something is completely anechoic or completely black, that it's a transudate. It could still be an exudate. But if you see fluid where the echogenicity looks more grey, or there's a swirling pattern to it, it's extremely unlikely that that fluid will be a transudate. And in this particular example, if you saw fluid like this in the wards or in the emergency department, you need to consider blood or pus, so an empyema. And that fluid would certainly need to be sampled. When looking at the lung suspended within a pleural effusion, it can sometimes look like a tongue, and we call this the tongue sign. And this is compressive atelectasis of the lung. Rib fractures are also quite easily identified with a high-frequency linear probe. And the technique for this is to ask the patient where they feel the point of pain, and then just explain to them that you're going to gently apply the probe in that area and be careful not to cause too much discomfort, but place the high-frequency probe over the length of the rib, over the site where they identify the maximal pain. And what you might see is something like this slide demonstrates, which is the rib cortex showing a break, a discontinuity at the site of the rib fracture. And this can be a more sensitive modality for picking up rib fractures than a standard chest radiograph. Now, pneumothorax is another commonly encountered emergency situation in the emergency department, and point-of-care ultrasound can also be useful in this context. It's very important to, again, apply the systematic examination techniques we talked about before, and also to go through an algorithm so that you do not rely on one particular sign to diagnose a pneumothorax, which may lead to a wrong diagnosis or a dangerous intervention. So, for example, a useful algorithm shown here on the right of this image is to ask yourself, do you see lungs sliding? Now, if you see lungs sliding, which implies the pleura opposed to each other, then you can effectively exclude pneumothorax. If you don't see lungs sliding, do you see B lines? If you see B lines, again, you do not see B lines in pneumothorax, so you can exclude pneumothorax. But if you don't see B lines, then you need to find something called a lung point, and this is the point at which you can see normal lungs sliding next to an area with no B lines and no lung sliding. And that's the area where pneumothorax meets the collapsed lung. If you can identify this, this will diagnose pneumothorax. If you can't find the lung point, but you can see the lung pulse, this is where the pleura are opposed but not sliding, and the lung transmits cardiac pulsation, then you've excluded pneumothorax. So it's a three-step process looking for lung sliding, B lines, and lung point or lung pulse. And if you can go through the algorithm, you can typically detect pneumothorax with a high degree of sensitivity. There are some cases where this examination can be quite challenging. For example, when people are unconscious and perhaps hypoventilating, it can be challenging to see lungs sliding. Also, patients on ventilators, it can sometimes be more tricky to identify all the usual ultrasound features. And on this slide, you can see normal lung sliding on the left with B lines. So these are the hyperechoic lines extending from the pleura to the base of the lung. And on the right, you can see that there's a lack of that movement of the pleural line. Another feature of the ultrasound examination which can be useful in pneumothorax is identifying features on M mode. So a typical pattern on M mode for normal lung would be to see the so-called seashore sign, and this is basically a series of horizontal lines at the top of the image representing the waves of the sea, and these are the subcutaneous tissues, and then a sort of a grainy image at the bottom of the picture, which is the beach, the grains of sand, and that's the texture of the lung. And the hyperechoic line that divides the two is the pleural line. In the context of a pneumothorax, very often you see this so-called stratosphere or barcode sign, which is just horizontal lines stretching across the entire image. And this can give you some further evidence that what you're seeing is not sliding lung and a pneumothorax. In terms of the lung point, as we discussed before, on the left-hand side you can see to the right of the image sliding pleura, that's the point of the lung or the lung point, and to the left of it what appears to be a hyperechoic line without sliding and no B lines, and that's the pneumothorax. So when you identify this by moving the probe down and laterally, then you can be quite confident that what you're seeing is a pneumothorax. And you can see a similar image to the right, where in one intercostal space you can see lung sliding, and then as you move up you can see a lack of lung sliding. So again, that identifies lung point. And lung pulse is demonstrated on this image. So you can see on the left chest there's normal sliding pleura. On the right chest, if you look closely at the image, you can see a kind of a pulsation and a hyperechoic line without sliding. This implies the visceral and parietal pleura are opposed, but for some reason there's no lung movement. This can be seen, for example, after right mainstem intubation where there's left lung atelectasis, and can be a very useful sign in this context. Hydropneumothorax, when you have air and fluid in the pleural space, can also be detected with ultrasound, and as you can see on this little video clip, to the left there's a hyperechoic area, which is the fluid, and the lung, which is hyperechoic, just inferior to it, and to the right this kind of hazy grey area, which is which doesn't show a sliding pleura sign or any fluid or lung, and this is the interface between the fluid and the pneumothorax. So putting this all together, Lichtenstein devised a protocol to assess the breathless patient, and he called this the Blue Protocol. And the Blue Protocol is an algorithmic way of deciding with a fairly high degree of sensitivity and specificity what the likely diagnosis in a breathless patient may be. And it starts with lung sliding. And if lung sliding is present, you then need to define whether the patient has a B profile, which is a predominance of B lines, or an A profile, which is a predominance of A lines. And A lines, as we said before, are a fairly normal lung artifact. So if you have a B profile, pulmonary edema is the most likely diagnosis in the breathless patient, particularly if you see diffuse lung rockets, if you see dependent pleural effusions, especially if they're bilateral. And of course, this can be followed on with Pocus echocardiographic assessment and assessment of intravascular volume by determining the inferior vena cava size and collapsibility. If you have an A profile, the next step in this protocol is to perform a deep vein thrombosis assessment, and if you find a DVT, the likely diagnosis in the breathless patient will be a pulmonary embolism. If, on the other hand, you find that the leg veins are normal, the next point is to look at the PLAPS point, which is the most posterolateral point in the patient. And if you see consolidation and or a pleural effusion, the likely diagnosis in that situation will be pneumonia. But if the PLAPS point looks normal, then this may be asthma or COPD, some other form of airways disease. So this is if you have lung sliding present. If there's no lung sliding, which is the right of the diagram, and you have the so-called B prime profile, so lack of lung sliding with B lines, which may be localized B lines, this could be pneumonia, consolidation. It could also be an infarct. It could be a lung contusion. If you have an A prime profile without a lung point or lung pulse, you need to refer to other diagnostic modalities, imaging modalities, to work out a diagnosis. If you have an A prime profile and you see the lung point, this is highly specific for pneumothorax. So this is no lung sliding, no B lines, lung point, and then you can confidently make a diagnosis of pneumothorax. And then you have the so-called gray area in between, where you may have lung sliding or you may not have lung sliding, or it's not entirely clear whether you do, and you have a mixture of an A and a B profile, or you have the C profile, which are these small subpleural consolidations. And this again can be an infective cause such as pneumonia, and in this current situation it can also represent COVID-19. So again, just to summarize the important points for lung ultrasound, you need to usually use a low frequency probe, perform a systematic examination, either 4 zones per hemithorax or 6 zones, and then ask yourself the questions: is there lung sliding? Do I see artifacts? And if I do, what are they? Do I see consolidation? Do I see pleural effusion? If you suspect a pneumothorax, you need to go through an algorithm asking yourself, do I see lung sliding? Do I see B lines? Do I see a lung point or a lung pulse? Once you've done that, the next question is, I've finished the lung ultrasound component. This is what I think may be the diagnosis. How can I confirm that with some additional ultrasound Pocus information? And this may include a DVT scan, it may include an echocardiogram, it may include an abdominal scan looking for free fluid in the abdomen. All of your ultrasound impressions need to be contained within a clinical context and a clinical question. And if you have additional imaging, such as a chest x-ray or a CT scan, you must also try and use that and incorporate that information. Just a few slides concerning COVID-19, as this is a current and pressing problem. There's plenty of evidence over the last year that there are some fairly distinctive features of COVID-19 lung disease, including the fact that there seems to be a progression from fairly normal lungs to ground glass changes that are typically basal, posterior, and subpleural, and this progresses through to a mixture of ground glass and consolidation, leading to frank consolidation. There also appears to be a high risk of pneumothorax, and of course the development of conventional bacterial pneumonias. These patients are also typically at higher risk of thromboembolic disease. So there are a variety of radiological, including ultrasound, features that can be detected, but typically we're looking for something that's subpleural, posterior, and basal. And there are some, although not pathognomonic, but fairly typical findings, including so-called subpleural consolidations and the C-line pattern. So these videos show you some examples of that, where you look at the sliding pleura sign, and then you can reduce the depth, change the focal point to the pleural line, or even use a high frequency probe to look at the pleural line, and you're looking for these hyperechoic subpleural areas. And we know that as the lung disease progresses, these areas become larger and more confluent. And this gives you an example of the difference between congestive heart failure on the right and COVID-19 changes on the left, where at initial appearance it looks like the pleural sliding is the same, but in congestive cardiac failure the pleural line is typically unbroken and smooth and hyperechoic. You will also, in congestive cardiac failure, have the so-called B-line pattern or lung rockets. You get exactly the same pattern of lung rockets in COVID-19, but the differentiating feature can be the so-called C-line pattern or subpleural consolidations. And the other feature about lung rockets in COVID-19 is that as the disease becomes more severe, and this correlates with symptoms and degree of hypoxemia, the lung rockets become more confluent. And it can lead to a feature called the so-called light beam or flashlight sign, where B lines merge together and appear and disappear like a flashlight. And this seems to be a fairly typical finding in severe COVID-19 pneumonia. And here's another video demonstrating that. And to give you an idea of how confluent lung rockets look, so in this example you can look at the pleural line and see subpleural consolidations, and you can see a very hyperechoic lung, an absence of A lines, and the appearance of the entire image is sliding with respiration. And these are confluent hyperechoic B lines. And in this particular case was a patient with COVID-19 at day 9, very hypoxemic. And here's the patient day 12, deteriorating with worsening hypoxemia and fever. And you can see in the right upper lobe there's also confluent B lines, and right lower lobe subpleural consolidation, small pleural effusion developing. So that's the end of the presentation on lung ultrasound. The following few slides are a quiz just to test your understanding of the topic area. You can go through the following several slides and write down your opinions, and I'd be very happy to run through the answers with you when we meet in the practical course in the near future. Thank you for your attention.